Good day. Our topic for today are the drugs that affect fluid and electrolyte balance. There are two major applications for diuretics. First is the treatment of hypertension, and second, the mobilization of edematous fluid associated with heart failure, cirrhosis, or kidney disease. In addition, because of their ability to maintain urine flow, diuretics are used to prevent renal failure. And now for the review of renal anatomy and physiology. The basic functional unit of the kidney is the nephron. The nephron has four functionally distinct regions: the glomerulus, the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule. In addition to the nephrons, the collecting ducts, the tubules to which the nephrons pour their contents, play a critical role in kidney function. The final segment of the distal convoluted tubule plus the collecting duct into which it empties can be considered a single functional unit, which is called the distal nephron. And now for the physiology, the kidney serves three basic functions. First, the cleansing of extracellular fluid, or the ECF, and maintenance of ECF volume and composition. Second will be the maintenance of acid-base balance. And third, the excretion of metabolic waste and foreign substances, such as your drugs and toxins. Of the three, maintenance of ECF volume and composition is the one that the diuretics affect most. The three basic renal processes are the following: filtration, reabsorption, and active secretion. First, filtration. Filtration occurs at the glomerulus and is the first step in the urine formation. Virtually all small molecules, such as your electrolytes, amino acids, glucose, drugs, and metabolic waste, are present in plasma undergo filtration. In contrast, cells and large molecules, such as your lipids and proteins, remain behind in the blood. The most prevalent constituent of the filtrate are your sodium ions and chloride ions. Bicarbonate ions and potassium ions are also present, but in smaller amounts. So the filtration capacity of the kidney is very large. Each minute, the kidney produces 125 ml of filtrate, which adds to 180 liters per day. Since the total volume of ECF is only 12.5 liters, the kidneys can process the equivalent of all the ECFs in the body every 100 minutes. Hence, the ECF undergoes complete cleansing about 14 times each day. Now, for the reabsorption. So, more than 99% of the water, electrolytes, and nutrients that are filtered at the glomerulus undergo filtration. This conserves valuable constituents of the filtrate while allowing waste to undergo excretion. The absorption of solutes takes place by way of active transport. Water then follows passively along the osmotic gradient created by solute reuptake. And so, diuretics work primarily by interfering with the absorption. Now, for the active tubular secretion. The kidney has two major kinds of pumps for active secretions. These pumps transport compounds from the plasma into the lumen of the nephron. One pump transports organic acids and the other transports organic bases. Together, these pumps can promote the excretion of wide assortment of molecules, including metabolic waste, drugs, and toxins. The pumps for active secretion are located in the proximal convoluted tubule. Now, for the processes of reabsorption that occur at specific sites along the nephron. Now, filtration occurs at the glomerulus and is the first step in the urine formation. Then, the proximal convoluted tubule, or the PCT, has a high reabsorptive capacity. About 60 to 65% of filtered sodium and chloride is reabsorbed at the PCT. Next would be the loop of Henle. The descending limb of the loop of Henle is permeable to water. Next would be the thick segment of the descending limb of the loop of Henle. About 20% of filtered sodium and chloride is reabsorbed. Next would be the distal convoluted tubule. About 10% of filtered sodium and chloride is reabsorbed in the early segment of the distal convoluted tubule. Water follows passively. And your distal nephron, your late distal convoluted tubule, and the collecting duct. The distal nephron is the site of two important processes. The first involves exchange of sodium for potassium and is under the influence of aldosterone. The second determines the final concentration of the urine and is regulated by the anti-diuretic hormone. About 1 to 5% of filtered sodium and chloride is absorbed. And now for the prototype drugs for your diuretics. For the loop diuretics, we have your furosemide. For your thiazide diuretics, we have your hydrochlorothiazide. And the prototype for your potassium-sparing diuretics are your spironolactone and your triamterene. Now, for the classification of diuretics, there are four major categories. You have the loop diuretics. Example will be your furosemide. Your thiazide diuretics. Example will be your hydrochlorothiazide. Third will be your osmotic diuretics. Sample will be your MANNITOL. And your potassium-sparing diuretics. Example will be your spironolactone. So the last group, the potassium-sparing, can be subdivided into aldosterone antagonists, such as your spironolactone, and your non-aldosterone antagonists, such as your triamterene. In addition to the four major categories of diuretics, there is a fifth group, the carbonic anhydrase inhibitors. Although the carbonic anhydrase inhibitors are classified as diuretics, these drugs are employed primarily to lower intraocular pressure and not to increase the urine production. Now for your loop diuretics. And now for the prototype of your loop diuretic is your furosemide with a mechanism of action wherein it acts in the thick segment of the ascending limb of loop of Henle to block the reabsorption of sodium and chloride. So by blocking the solute reabsorption, furosemide prevents passive reabsorption of water. Since a substantial amount or 20% of filtered sodium chloride is normally reabsorbed in the loop of Henle, interference with reabsorption here can produce profound diuresis. Now for the pharmacokinetics, furosemide can be administered orally, IV, and IM. With oral administration, diuresis begins in 60 minutes and persists for 8 hours. The effects of IV furosemide begin within 5 minutes and last for 2 hours. And intravenous therapy is used in critical situations. Furosemide undergoes hepatic metabolism followed by renal excretion. The therapeutic uses of furosemide. It is a powerful drug that is generally reserved for situations that require rapid or massive mobilization of fluid, such as your pulmonary edema associated with congestive heart failure, edema of hepatic, cardiac, or renal origin that has been unresponsive to less efficacious diuretics, and hypertension that cannot be controlled with other diuretics. And now for the adverse effects of your furosemide. First is the hyponatremia, hypochloremia, and dehydration. Furosemide can produce excessive loss of sodium, chloride, and water, and severe dehydration can result. It can also cause hypotension. Furosemide can cause a substantial drop in your blood pressure. Next will be hypokalemia. Potassium is lost through increased secretion in the distal nephron. Next will be the ototoxicity. Rarely, loop diuretics can cause hearing impairment. With furosemide, deafness is transient. Next will be the hyperglycemia. Elevation of plasma glucose is a potential, though uncommon, complication of furosemide therapy. It appears to result from inhibition of insulin release. Next will be hyperuricemia. Elevation of plasma uric acid is a frequent side effect of treatment. Furosemide-induced hyperuricemia is asymptomatic. And there is an impact on lipids, magnesium, and calcium. So furosemide reduces your high-density lipoprotein or your HDL cholesterol and raises your LDL. It also raises your triglycerides. Furosemide increases urinary excretion of magnesium, posing a risk of magnesium deficiency. And furosemide can also cause increased urinary excretion of your calcium. And now, for the drug interactions, digoxin, because loop diuretics promote potassium loss, the use of these drugs in combination with digoxin can increase the risk of dysrhythmia. Ototoxic drugs. The risk of furosemide-induced hearing loss is increased by concurrent use of other ototoxic drugs such as your aminoglycosides as exemplified by gentamicin. Now for the potassium-sparing diuretics, the potassium-sparing diuretics such as your spironolactone can help counterbalance the potassium-wasting effects of your furosemide. Next will be your lithium. So lithium is used to treat bipolar disorder. So in patients with low sodium, excretion of lithium is reduced. Hence, by lowering your sodium levels, furosemide can cause lithium to accumulate to toxic levels. Next will be your antihypertensive agents. The hypotensive effects of the furosemide to those of other hypotensive drugs can be aggravated. Next will be your NSAIDs or your non-steroidal anti-inflammatory drugs. So aspirin and other NSAIDs can attenuate the diuretic effect of furosemide. So these are the loop diuretics routes, the time course, and the dosage. Now for your thiazide and related diuretics. So the prototype is your hydrochlorothiazide. The mechanism of action is that it promotes urine production by blocking the reabsorption of sodium and chloride in the early segment of the distal convoluted tubule. So retention of sodium and chloride in the nephron causes water to be retained as well, thereby producing an increased flow of urine. Because only 10% of filtered sodium and chloride is normally reabsorbed at the site where the thiazides act, the maximum urine flow of these drugs can produce is lower than with the loop diuretics. So for your pharmacokinetics, diuresis begins about 2 hours after oral administration. Effects peak within 4 to 6 hours and may persist up to 12 hours. Most of the drug is excreted and changed in the urine. Now for the therapeutic uses of your hydrochlorothiazide is for your essential hypertension. So this is the primary indication of HCTZ. Edema. So thiazides are preferred drugs for mobilizing edema associated with mild to moderate heart failure. And for your diabetes insipidus, so diabetes insipidus is a rare condition characterized by excessive production of urine. So in patients with this disorder, thiazides reduce urine production by 30 to 50%. And protection against postmenopausal osteoporosis. So your thiazides promotes tubular reabsorption of calcium and may thereby decrease the risk of osteoporosis in postmenopausal women. But the adverse effects of your thiazide are the following. It is similar to those of the loop diuretics. And these are the dosages and the time course of effects for your thiazides and related diuretics. Now, for the potassium-sparing diuretics. So, for the mechanism of action, spironolactone blocks the action of aldosterone in the distal nephron. Since aldosterone acts to promote sodium uptake in the exchange of potassium excretion, inhibition of aldosterone has the opposite effect, which is retention of potassium and increased excretion of sodium. So the effects of spironolactone are delayed, taking up to 48 hours to develop. The therapeutic uses of the spironolactone are the following: for hypertension and edema, and for heart failure. So in patients with severe heart failure, spironolactone reduces mortality and hospital admissions. For the adverse effects, we have your hyperkalemia. So the potassium-sparing effects of spironolactone can result in hyperkalemia, wherein it can produce fatal dysrhythmias. We have endocrine effects. So spironolactone is a steroid derivative with a structure similar to that of a steroid hormone. So as a result, spironolactone can cause a variety of endocrine effects, including gynecomastia, menstrual irregularities, impotence, hirsutism, and deepening of the voice. Next will be the triamterene. So the mechanism of action of triamterene, it disrupts your sodium-potassium exchange in the distal nephron. It is a direct inhibitor of the exchange mechanism. So it decreases in sodium reabsorption and reduction in your potassium secretion. And it acts much more quickly than your spironolactone. We have here the amiloride. So amiloride inhibits potassium loss by direct blockade of your sodium-potassium exchange in your distal nephron. It is used primarily to counteract potassium loss caused by your more powerful diuretics. And its major adverse effect is hyperkalemia. So these are your potassium-sparing diuretics, the dosages, and the time course of effects. And we have mannitol, which is the osmotic diuretic. It is freely filtered at the glomerulus, and it undergoes minimal tubular reabsorption. It undergoes minimal metabolism. It is pharmacologically inert, that is, it has no direct effects on the biochemistry or physiology of the cells. So following an IV administration, mannitol is filtered by the glomerulus. However, unlike other solutes, the drug undergoes minimal reabsorption. So as a result, most of the filtered drug remains in the nephron, creating an osmotic force that inhibits passive reabsorption of water. Hence, urine flow increases. The degree of diuresis produced is directly related to the concentration of mannitol in the filtrate. The more mannitol present, the greater the diuresis. Mannitol has no significant effect on the excretion of your potassium and other electrolytes. For the pharmacokinetics, mannitol does not diffuse around the GI epithelium and cannot be transported by the uptake system that absorbs dietary sugars. So the drug must be given parenterally. So following IV injection, mannitol distributes freely to extracellular water. So diuresis begins in 30 to 60 minutes and persists 6 to 8 hours. So most of the drug is excreted intact in the urine. So for the therapeutic uses of your mannitol, first is your prophylaxis of renal failure. So because filtered mannitol is not reabsorbed, even when filtrate volume is small, filtered mannitol will remain in the nephron drawing water with it. Hence, mannitol can preserve urine flow and may thereby prevent renal failure. Second, it can be used for the reduction of your intracranial pressure. So, your ICP or your intracranial pressure has been elevated by cerebral edema and can be reduced by your mannitol. So the drug lowers your ICP because its presence in the blood vessels of the brain creates an osmotic force that draws edematous fluid from the brain into the blood. There is no risk of increasing cerebral edema because mannitol cannot exit the capillary beds of the brain. It is also used for the reduction of intraocular pressure. So mannitol and other osmotic agents can lower your IOP by rendering the plasma hyperosmotic with respect to intraocular fluids. So the hyperosmotic plasma creates an osmotic force that draws ocular fluid into the blood. The use of the mannitol to lower IOP is reserved for patients who have not responded to more conventional treatment. Now for the adverse effects of your mannitol, first is your edema. So mannitol can leave the vascular system at all capillary beds except those of the brain. So when the drug exits capillaries, it draws water along, causing edema. So mannitol must be used with extreme caution in patients with heart disease, since it may precipitate CHF and pulmonary edema. And there are also other adverse effects. Common responses include headache, nausea and vomiting, and fluid and electrolyte imbalance may also occur. Thank you for watching.